Evening. Our Spring 2007 lecture series continues with tonight's discussion, heavy metal detoxification and cardiovascular disease stabilization utilizing EDTA Chelation therapy. My name is James Roberts. I'm board certified in internal medicine and in cardiology. I've been practicing invasive and integrative cardiology in Northwest Ohio over the past 10 years. I'm a fellow of the American College of Cardiology. I'm board certified in chelation therapy, and I'm active in several professional societies that focus on detoxification, including the International College of Integrative Medicine, ACAM, the American College of Alternative Medicine, and IAOMT, the International Association of Oral Medicine and Toxicology, and I'm a site investigator of TACT, the Trial to Assess Chelation Therapy, a NIH-sponsored study of chelation therapy in individuals with known cardiovascular disease. Chelation therapy is discussed in Reverse Heart Disease Now, a patient's manual of integrative cardiology written by myself and my colleague Stephen Sinatra, and information about chelation therapy and other integrative approaches to cardiovascular medicine are included on our website, heartfixer.com. We're going to discuss tonight the medical applications of EDTA chelation therapy. EDTA is the molecule that we'll be utilizing, that we'll be discussing. Now, EDTA can be administered in many different forms, which we're not going to talk about tonight, such as the calcium EDTA rapid push, nanobac EDTA, or detox max, where the EDTA is mixed with phosphatidylcholine in an oral format. These are other delivery systems of EDTA that we are not going to be focusing on tonight. Tonight, when I use the term chelation therapy, I'll be referring to the 3-hour slow infusion of magnesium EDTA. And we will be using magnesium EDTA to stabilize cardiovascular disease and to reverse cognitive decline when it is due to heavy metal overload. Chelation therapy removes toxic heavy metals. That's how it works. EDTA removes lead and cadmium. It will remove iron, but if we're interested in iron, we'll use another agent called desferoxamine. EDTA has some efficacy with mercury. We'll be speaking on mercury at another presentation. With mercury, we'll also use DMPS and DMSA. EDTA can remove aluminum, nickel, and arsenic. By removing heavy metals, we feel we stabilize cardiovascular disease, reverse cognitive decline if it is due to metal overload, and we can stabilize or reverse mild to moderate kidney disease, again by removing the toxic heavy metals. I was taught that chelation therapy was a dangerous procedure of no benefit, administered only by failed doctors who couldn't make it in the real world. And I would advise my patients not to undergo chelation therapy. As a matter of fact, if you wanted chelation therapy, you have to leave my practice. I won't be associated with chelation therapy. And then a bunch of my patients went and underwent chelation therapy behind my back and got better, a lot better. These were people who I told them they would die without bypass surgery, and they declined my wise advice. And I would see them in the office and say, "Are you ready for your bypass? Because you're going to die without it." "Oh, Dr. Roberts, give me a little bit more time." I'd see him 3 months later. "Don't you think you need more medicine? Don't you think you need your bypass?" "Oh, Dr. Roberts, give me a little bit more time." So I'd see him every few months and say that they're going to die without bypass surgery. And then a couple years would go by, and I'm about to tell them that they're going to die without bypass surgery, and I noticed that they're looking really good, and they're feeling really good, and then they blurted out, "Dr. Roberts, I went and got chelation therapy." This was very embarrassing to me, because they weren't supposed to get better because it didn't work, and they got better. So I learned from my patients about chelation therapy, began to treat my own patients with chelation therapy with very positive results. Some of my early experiences that really got me excited about this, JG had a balloon angioplasty in '95. He re-narrowed, had a bypass surgery. He developed 2 strokes as a complication of the bypass. I met him in '97. He could walk 18 minutes and 16 seconds. His stress echo showed a prior heart attack and additional heart muscle at risk. He had kidney dysfunction. His creatinine was elevated. It should be about 1.2, so his kidneys aren't working so well. So if I do a heart cath, I might damage his kidneys. His other doctors really hadn't looked at his risk factors. They're busy doing procedures on him. He has a high LPA, high homocysteine, diabetes. So we put him on a nutritional program, vitamins, minerals, essential fatty acids. And he received 30 EDTA treatments and then maintenance chelation. He received external counterpulsation. His symptoms went away. We did a dobutamine stress echo. There was no additional ischemia. And his kidney function improved. That was kind of nice. CB had a massive heart attack in '86. He had a bypass surgery, got hepatitis C, had a laser angioplasty in Detroit in '92. Then he got involved in nutritional therapy. He saw some of the big guys. He went and saw Whitaker and Adkins and received chelation and nutritional intervention and did very well. And he lives in Toledo, and when I got involved in this, he came to see me, and I kept up the chelation. We gave him phosphatidylcholine, which promotes reverse cholesterol transport. We'll talk about that a little bit tonight. And he did great. He just felt great. He's in his 80s. He's on just a few medications. But then he wanted to take Viagra. Now, he's in his 80s, and he wants to take Viagra, and I had him on some long-acting nitrates, so you can't take both. So I said, you're really sure you want me to rock the boat? You're doing so well. Yep, I want to take that Viagra. Well, I understand. That's fine. So we backed off on his nitrates, and he took Viagra, and he was kind of dizzy, and we weren't sure what to do, and I thought, I better do a heart cath and make sure this is okay. We do a heart cath. He's 14 years out from his bypass. We found two grafts, two major vessels closed. That's old business. His 14-year-old vein grafts look great, and his Lima graft looked great. 1 out of 3 vein grafts closes the first year. Half of them are closed at 7 years. This guy looks great 14 years out. I thought that was a neat result. LB had an abdominal aortic aneurysm repair and a left carotid endarterectomy in '80. In '83, popliteal artery aneurysms behind his knees were repaired. 2 arteries in his heart required balloon angioplasty in '93. 3 years later, they closed, and he had 2 stents placed. He had recurrent angina in '97. There's 50% narrowings within the stents. I saw him in '98. He's having chest pain. He's having claudication, poor blood flow to the legs. His ankle brachial index, it should be 1.0, was mildly impaired at 0.9 on the right and moderately impaired at 0.65 on the left, and they proposed more angioplasty, more surgery. He was sort of reviewing the situation, saying, this isn't working all that well. I'm just having a surgery every couple of years. So he saw me. We put him on the standard nutritional program. He got 30 chelations with maintenance. His chest pain went away. I did a dobutamine stress echo. 2 years later, it looks great. We've been following him over the last 6 years with periodic stress studies, carotid ultrasounds, lower extremity blood flow studies, and he's been stable. We stopped chelating him in 2001 related to cost issues. He has not batted an eyelash. He needed a major non-cardiac surgery in 2005. I got nervous about him. I did a heart cath, and he had non-obstructive narrowings in his coronary arteries. His coronaries looked better in 2005 than they did in 1997. So that's really a nice outcome. I love turning people around by taking the poisons out of their body, the poisons that wanted to plug them up in the first place. The clinical effects of chelation up to a 90% response rate in angina and claudication, proven to increase arterial flow. All you got to do is open up that narrowed artery a little bit, and you can improve flow dramatically. Provides effective treatment of heavy metal toxicity, stabilizes declining kidney function, benefits in other degenerative diseases, may decrease risk of future malignancy, improves lung, kidney, and overall metabolic function. Chelation lowers your blood pressure, exercise blood pressure, exercise heart rate. It makes your arteries more elastic. Favorable effect on many risk factors: cholesterol, ferritin, which is stored iron, homocysteine and lipoprotein may fall. It blunts the oxidation of LDL cholesterol, increases HDL and our antioxidant vitamin C related defenses. Risk of toxicity is minimal, no deaths have been reported, extremely cost effective. What this means to you is that chelation can help stabilize your cardiovascular disease, not in isolation, but as part of an overall integrative program, giving you the opportunity and responsibility to maintain your now improved health, freeing you of dependence on drugs, hospitals, and doctors. And you don't want to be dependent upon us. You want to be dependent upon yourself. LF did not want to be dependent upon drugs and doctors and hospitals. She presented in 1996 with unstable angina. A heart cath demonstrated 80 to 95% narrowings in all three arteries. Bypass surgery was recommended. I would have recommended bypass surgery. She declined and underwent chelation therapy. She got 50 treatments between 96 and 99. I met her in 99. She could walk 9 minutes on this treadmill, and her stress echo was abnormal, as I expected. She did not wish to be considered for revascularization. And we put her on a standard nutritional program with only minimal maintenance chelation. She had some back pain in 04. I wasn't sure what was going on. We did a stress echo. It was abnormal, but her treadmill time was down from 9 minutes to 5.5 minutes, so I talked her into a heart cath with great difficulty, and she looked better in 04 than she did in 96. Her arteries had not worsened. In fact, they opened up a little bit. I offered her open heart surgery. She said, "Why are you even wasting your time, Dr. Roberts?" So we treated her with more chelation, and she has minimal angina. She certainly stabilized well. The biochemical effects of chelation. How do we get these clinical effects? Well, we're going to lower the intracellular calcium to magnesium ratio, which is high in our patients. We're going to remove the toxic non-protein bound iron. We're going to squelch damaging free radical reactions. We're going to remove toxic metals, improving enzyme function. We're going to replete deficient vitamins and minerals and essential fatty acids. We're going to have a weak but important antiplatelet, anti-clotting effect, and a favorable effect on multiple cardiovascular risk factors, which we've touched on earlier. This is EDTA, ethylene diamine tetracetic acid, quite a mouthful. We're going to call it EDTA. EDTA is a hexadentate chelator. It has a configuration like a claw. And at the point of the pincers, EDTA can bind to a metal. We administer to you EDTA into an IV. It will grab a metal from your blood and take it out through the urine. That's all it does. It's out of your body within 6 to 9 hours. All EDTA chelation does is remove abnormal toxic metals from your body. What metals are we going to remove? Well, that's a function of what abnormal metals you have in your body, where they are, whether we can get at them or not with EDTA, and the binding avidity of the metal to EDTA. This is the order of binding affinity or avidity to EDTA in a test tube situation. EDTA binds least tightly to magnesium. So what we're going to do, we're going to react EDTA and magnesium in the IV bottle and give you magnesium EDTA. So these magnesium EDTA complexes enter your vein. The magnesium EDTA is going to come across a calcium. EDTA binds more avidly to calcium than magnesium, so it gives up the magnesium and binds a calcium. Great. So I can give you magnesium, something I want to do. So this EDTA calcium's floating around. It comes across aluminum. It's going to give up calcium and bind aluminum. As it floats around in your circulation some more, it may come across lead. It'll give up the aluminum and grab lead. As this EDTA is floating around in your circulation over 6 hours, it's constantly grabbing and giving up metals. And then it's going to pass through the kidney and out through the urine, and whatever it's holding on to at that time leaves the body. Now, you'll notice that mercury is on the list. EDTA binds tightly to mercury, but clinically, EDTA is a poor mercury chelator because it can't get at the mercury. It's in the cells. We'll talk about mercury later on. We'll use other chelators. But these metals in red are going to be removed with chelation, and we're going to give you magnesium. Now, EDTA can also take out some good physiologic metals like copper and zinc, so I could render you mineral deficient if all I did was treat you with magnesium EDTA. And I'm not going to do that. I'm going to recommend a broad spectrum vitamin and mineral supplement, as I do to everybody, chelation patients, patients in general, people who don't want to be patients, to prevent mineral deficiency. As a matter of fact, if you're a new patient and you're on a lot of drugs and I think you're sick, the first thing I'm going to do is give you vitamins and minerals IV to make sure I can optimize your nutritional status. Then I'm going to treat you with chelation. The dose of EDTA is a function of your age, gender, size, body surface area, and kidney function. And this will be individualized to you. I'm going to react EDTA with an equivalent dose of magnesium. Now, EDTA is an acid that would burn like fire going in your IV, so we're going to buffer it with sodium bicarbonate. And even then, it would sting a little bit, so we're going to put in a little Procaine local anesthetic and heparin to prevent phlebitis, and we're going to give you some B vitamins, and this would be a hypotonic solution, inappropriate to administer, so to make it isotonic with blood, we're going to give you 5 to 10 grams of vitamin C. So we're giving you EDTA with some other good stuff and magnesium and vitamin C. How does this all work? Here is a sick cell. It's got a high calcium to magnesium ratio, it's got small doses of nutritional metals, and it's got a lot of toxins. And the blood of this person has more calcium than it should, a high calcium to magnesium ratio. There's some good minerals and there's some toxic minerals floating around in equilibrium between the blood and in the cells. And this cell's sick, so it's covered with plaque. So we're going to give you EDTA magnesium, and we've also been supplementing with nutritional minerals. So the EDTA magnesium is going to give up the magnesium and bind some calcium. So EDTA calcium will go out through the kidney. Some of the EDTA magnesium will give up magnesium and bind some of the toxic metals like cadmium, iron, and lead and take them out through the kidneys. So we're going to acutely lower the concentration of calcium and toxic metals in the blood. And we're going to acutely increase the amount of magnesium, and we're supplementing you with good minerals. So what's going to happen over the next week or so, that magnesium is going to go into the cell, calcium will leave the cell to follow the equilibrium gradient with the low calcium in the blood, and some of the toxic metals will come out. So we're going to do this over and over, once a week for 30 or so weeks. Each time we're going to lower the concentration of calcium and the toxic metals in the blood. We're going to leach some of the bad stuff out of the cells into the blood. Magnesium and good supplements go from the blood into the cell. When we're done, we've cleaned out the blood, we've cleaned out the cell, we've removed toxic metals from the body, we filled up your tank with good metals, your enzymes work better, and your artery is healthy. That's all we're doing with chelation. We're putting good minerals in, taking bad toxic metals out. What are these heavy metals that we're talking about? Lead, cadmium, arsenic, nickel, aluminum, and mercury. They're not normally present in the human body. Mother Nature did not intend us to take in these metals. There's no beneficial role, they're pure toxins. But they're ubiquitous in the environment of modern man, but it's a new development. You know, we weren't exposed to lead until the Industrial Revolution. We weren't supposed to be exposed to mercury or aluminum or arsenic, so our bodies are not good at dealing with or defending against them because Mother Nature never planned on this. How do they hurt us? They cause free radical stress, they degrade nitric oxide, they displace nutritional minerals, and the key is they inactivate enzyme systems. Our physiology is run by enzymes, proteins. They all have a step on the biochemical assembly lines of life. An enzyme will grab a substrate, a raw material, and an energy packet, like ATP, and process it, manipulate it, release the product, and then the next enzyme in the assembly line will manipulate it and change it. That's how we build things. That's how we repair things. This enzymatic assembly line. So the enzymes must be working well. What heavy metals do, they look a little bit like a normal structure. So the enzyme grabs the heavy metal, but it can't do anything with it, and then it can't let go. So the enzyme is permanently destroyed. So there may be some substrate for this chemical reaction, but the enzyme's gone. You have to make a new enzyme, but if you make new enzyme and there's toxins, it'll just get wiped out. So one by one, our enzyme systems get knocked out by these toxic metals in a more or less permanent fashion. So our physiology stops working and we get sick. How do we diagnose metal overload or toxicity? Let's focus on lead because it'll be a little bit simpler for me. Hair analysis, blood and urine, red cell levels, organ biopsy, or a provocative study. Well, hair analysis, we look at the amount of metals in your hair. say the amount of lead, but there's some problems with it. It's only the amount of lead the body is excreting. If you're all poisoned up, you have retention toxicity. The enzymes involved in excreting lead are poisoned, so you're really sick, but we don't see anything in your hair. The hair can be contaminated with sprays and shampoos, this sort of thing, but it's low in cost, it's available to non-physicians, it's very, very difficult to interpret. So from my point of view, hair analysis is not helpful. There is a practitioner in southern Michigan who's very, very good at this, and he can get a lot of information out of hair analysis, but I cannot. The standard laboratory is pretty much useless. Your blood lead level reflects pretty much recent exposure, not long-term exposure. If you work in a battery plant and your blood lead level is high, they give you a 2-week vacation, you come back, your blood level is low, they say you're okay. You're not okay. During that 2 weeks, the lead left your blood, went into your internal organs. So blood lead level and pretty much urine lead and other metals reflects recent exposure. We're interested in total body burden. So I rarely, if ever, order standard laboratory values because they don't mean much. Red cells live for 3 months. We can look at the amount of metals in your red cell. That gives us like a 3-month average of what's been floating around, but it's kind of misleading. It's good for nutritional metals. This will tell me, are you getting in enough of the good nutritional metals? So the red cell study is helpful, but it can be misleading. Here's someone who has a red cell lead level at the 95th percentile. You'd think their only problem is lead. Then we did a provocative challenge where we administered DMPS and EDTA, and you can see they've got cadmium, lead, mercury, and nickel. They have all kinds of metals that we would have missed had we relied simply on blood tests or hair tests or a red cell study. The best, we could do an organ biopsy. That would be helpful, but of course it's not practical. And different metals will accumulate differently in different organs. 85% of the lead and cadmium in your body is in your bones. So if we just biopsy your kidney, we would miss the boat. The provoked urine test is the best approach. What we're going to do here, we're going to give you chelating agents that go in and bind the metals. What are the metals that we can mobilize? Then we collect urine for 6 hours and see what metals come out. It's not a perfect test, but it's the best one we have. And what I do, it's called the triple challenge. We give you an oral agent that has EDTA and garlic and selenium, which will begin this process of detoxification. I give you oral DMSA, which gets lead, cadmium, and mercury. IV EDTA, which is good for lead and cadmium, not so good for mercury. DMPS, which is not so good for cadmium, but it's great for mercury. And I collect urine for 6 hours. I'm going to give you a panel of chelators that will look for all the metals. If I simply gave you DMPS, I'd see mercury but not cadmium. If I simply gave you EDTA, I'd see lead and cadmium but not mercury. I'm interested in all the metals. So my decisions are made on the results of a challenge study. Here's someone that had a lot of cadmium and lead, lesser aluminum. I would treat them with EDTA. This person had an off-the-chart amount of lead and some mercury. I'd start with EDTA. Later, I would use DMPS. However, this gentleman had predominantly mercury. I would treat him with a mercury chelator such as DMPS. This gentleman had antimony and bismuth. I had no idea where he got that stuff. Now, oral EDTA alone is not an effective intravascular lead chelator. Oral EDTA is inactivated by stomach acid. Only 2 to 4% gets into your blood. So that's not very efficient. But it can still help us. Oral EDTA assists IV chelation. And let's review how our body attempts to detoxify lead through the GI tract. Lead in blood is taken up by the liver. The liver is a detoxification organ, but it has to make the lead water soluble. So it binds it to glutathione, which is a key antioxidant detoxifier. So the liver is going to dump the lead glutathione complex into the bile and into the gut. And if you're moving your bowels 3 times a day, you're going to get rid of it. But if you're not moving your bowels on a regular basis, and you may not be because you're metal toxic, if you're constipated, what will happen is the bond between the lead and the glutathione breaks, the glutathione's lost, and you're going to resorb the lead back into your blood, and it's going to go back to the liver, and you're going to keep recycling the lead between your liver and your gut and your blood. Each time you're going to waste glutathione. This is why heavy metal poisoning is such a problem. It's bad enough to have the lead in you, but your body's incompetent attempt to detoxify makes you sicker by causing free radical stress and wasting glutathione. This is why you want to avoid heavy metal toxicity. Now, what if we gave you oral EDTA? We're going to give you some oral EDTA. Some's going to be absorbed in the blood and will take out metals through the kidney. The EDTA in the blood binds tightly to lead. Some of the EDTA lead goes out through the kidney, some through the liver. And then the unbound lead is going to be taken up from the blood by the liver. The liver is going to bind the lead to glutathione to form the water-soluble excretion complex. The lead glutathione enters the bile, it goes into the intestines. If you're not moving your bowels, the lead glutathione bond breaks, and now you got the free lead in your intestines. But if there's a lot of EDTA in the gut, it'll bind up that lead, it goes out in the stool. So whenever we give you IV EDTA, we're going to give you oral EDTA. The IV EDTA, most of that's going out through the kidney, but we will also enhance the amount that goes out through the gut. So oral EDTA itself is inefficient, not ineffective totally, but it's inefficient, but it will combine it with IV EDTA to get the best result. Lead, where are we going to get lead? Paint, auto exhaust, water, tobacco, industrial waste. It inactivates enzyme systems, causes free radical stress, kicks out good minerals, degrades nitric oxide. In adults, 95% is in our bone, and the average American has 100 times as much bone lead as did the average American 100 years ago. That's not a good thing. It causes hypertension, cardiovascular disease, and kidney disease. Now in kids, it's different. They store it in their soft tissues and blood. We used to say the safe level of lead in a kid was 40 micrograms per deciliter. As more and more research came out, the safe level has been reduced to 10. Now, with kids, they're more susceptible. They absorb it better through their GI tract. We pick up 5 to 10% of the oral lead into our body. Kids will pick up 25 to 40%, and they get hit in their developing nervous system. So kids get neurodevelopmental disease. Now, the safe level is less than 10, but about 1 million American kids have blood lead levels above 10. 35% in some eastern cities. The lead from the automobile exhaust is still in the dirt and house dust in our major cities. It's not biodegradable. So nearly 1 million kids have blood lead levels of 10 or more in the United States. Now, we're saying that 10 is safe, but if your kid's blood lead level is 10, his or her IQ is going to be 7.5 points below that of the kid next door whose level is 0 to 1. So a safe level of lead in your kid is going to lower their IQ 7.5 points. That's the difference between your kid growing up to being a teacher or having to do something else like be a decision maker in a health insurance company. Lead levels above 3 are associated with delay in puberty. Kids who are troubled, who are getting into trouble in juvenile detention homes, all have higher lead levels than emotionally healthy kids. Now, a blood level above 10 is associated with an increased neurological risk in kids, but we've just shown that any lead is associated with intellectual dysfunction in kids. A blood level above 10 is associated with increased cardiovascular risk in adults. 99% of us have blood lead levels below 10. Only 1% of us have a high level. Should we worry? Well, we're worrying about our kids. Maybe we ought to worry about ourselves. Is a normal blood lead level in an adult associated with no risk of cardiovascular disease? Let's take a look at this. Lead and hypertension. Adult blood lead levels have dropped over 90% over the last 20 years. We took lead out of gas. But lead is locked into our cells and never leaves. And if we look at bone lead, the normative aging study looked at many parameters of ostensibly healthy Americans with age. And if you look at bone lead, with age, it steadily increases. It's a one-way street into our body. Once it's there, we have a lot of trouble getting rid of it. As your bone lead level rises from the lowest to the highest quintile, your risk for hypertension rises by 50%. Now, lead will degrade nitric oxide, lead to high blood pressure that causes kidney damage, and it's a direct toxin of the kidney. If we plot blood lead against serum creatinine, which is a marker of kidney dysfunction, the more lead, the worse your kidneys. Kidney function declines over time. That's inevitable with aging. But if you are in the upper quartile for lead, your kidneys fade a lot more rapidly than if your lead levels are low. Lead and hypertension in women. We're going to take women with normal blood lead levels and divide them into quartiles, all within the normal range. The women in the upper 25% for blood lead, well within the normal range, are 3.4 times as likely to have hypertension as women in the lowest quartile. That's premenopausal women. In postmenopausal women, the ratio is 8 to 1. Why at about the time of menopause is your blood pressure going up? I've had patients, female patients, their blood pressure soars with menopause. Why? As your bone mineral density decreases, all that lead that you've been storing up goes into your blood. So you have more or less acute lead toxicity. Of course your blood pressure is going to go up. Here's just over 1,400 healthy Americans in the NHANES, National Health and Education Nutrition Education Study. You're going to look at their blood pressure, standard cardiovascular risk factors, blood lead levels. You're going to exclude from analysis 707 that had abnormal blood lead levels, 1% of the population above 10. We're going to take 99% of the population with normal blood lead levels, divide them into terciles, 30% brackets for blood lead. The mean level was 2.6, that's the average. The first top tercile was 0 to 1.9. The middle tercile, 1.9 to 3.6. The upper third was above 3.6. We're going to look at mortality and cause of mortality over the next 12 years. All-cause mortality was not increased by being in the middle tercile for lead, but in the upper tercile, you're 30% more likely to die. Cardiovascular mortality rose 6% in the middle tercile, but it rose 64% in the upper third. So if your level's 3.6 or above, you're 64% more likely to die of cardiovascular disease over 12 years as opposed to someone whose level's 1.9 or below. Not a big difference in blood lead, but a big difference in your outcomes. Heart attack mortality, your risk doubles in your third tercile. Stroke mortality, if you're in the middle tercile versus the lower tercile, your risk of dying of a stroke rises 2.2-fold, twice as much, and 2.6 times as much in the upper tercile. Wow. Now remember in our first presentation I showed you the relative risk of high or middle tercile cholesterol and HDL and LDL, and I pointed out that the key predictor was oxidized LDL. Second and third terciles, really dramatically increased risk. Kind of looks like the heart attack and stroke mortality curves, doesn't it? Because heavy metals catalyze the conversion of superoxide and hydrogen peroxide, free radicals we make, into hydroxyl, which is lye. These toxic metals are they're creating the free radicals that are oxidizing our LDL. It's not the cholesterol, it's the oxidation. The metals are the key oxidizers. So of course they're going to increase your risk of cardiovascular disease. Cadmium, we can get from our mothers, it crosses the placenta. We can get it from batteries, from metal coatings, tobacco smoke, causing all kinds of disease states, including premature birth, low birth weight, hypertension, kidney disease, cardiovascular disease, osteoporosis, and cancer. It stays in our body. The half-life is 20 years. Wow. We grow our tobacco in Virginia, North Carolina, because they have the highest soil cadmium levels. The tobacco plant loves cadmium. If you do a kidney biopsy, smokers have more cadmium than non-smokers. So we can get some from food and industry, but we get most of it from smoking. Hard water, full of calcium and magnesium is protective against hypertension and cardiovascular disease, but not in Kansas City, Kansas. Kansas City, Kansas and Kansas City, Missouri draw their water from the same source, but in Kansas City, Kansas, the water is twice as hard as that of the soft water in Missouri. So you'd think that you'd have less cardiovascular disease with the hard water, but you don't. Blood pressure is higher in Kansas City. Serum cadmium is 10-fold higher in Kansas City, Kansas than in Missouri. They made a mistake and they hardened the water in a process that brings in cadmium. Now, Kansas City, Kansas, just a little bit north of Oklahoma, And what I say that to increase the business of the cardiologists in Kansas City, Kansas, they've gone just about as far as they can go. Cadmium and hypertension is a big problem in the Orient. They flood the fields with water to grow the rice, and they've got contaminated water. So there's a real problem. We look at Chinese women with and without essential unknown cause hypertension. Serum cadmium is nearly twice as high in the hypertensives as those with normal blood pressure, and there's much more in the urine. Cadmium and cardiomyopathy. 43 patients with dilated cardiomyopathies, their heart is punk, it's not working well, it's not due to blocked arteries, it's like a muscular dystrophy of the heart. And you got 17 age-matched healthy controls, and what you find that blood cadmium is twice as high in the cardiomyopathy patients than normal people. The urine cadmium is about the same, so perhaps they have a problem getting the cadmium out. Smokers always have higher cadmiums than non-smokers, but if you look at the non-smokers, those that have the cardiomyopathy, their level is 4 times as high. Of the smokers, those that have the cardiomyopathy, their levels are twice as high. So cadmium is associated with cardiomyopathy. Cadmium, lead, and synergy of toxins. If we find how much lead it takes to kill 10% of a population of rats, we call that the LD10. Then we'll figure out how much cadmium it takes to kill 10% of the rats. So if we give the LD10 of lead and the LD10 of cadmium to another group of rats, they all die. Because lead will poison some enzymes, cadmium will poison some other enzymes. Phthalates poison some enzymes. Trans fats poison some enzymes. The more toxins you have, the greater is your risk. You're wiping out your enzymes and they synergize. Here, let's look at 75 patients who died in North Carolina. You'll look at cause of death and look at lead in the aorta and liver cadmium and correlate cause of death, why they died, with their body burdens of lead and cadmium. And they died of a wide variety of causes, as you'd expect. Here, we're going to look at rising levels of lead, rising levels of cadmium. In X are the people that died of heart disease. In the circles are people that died of something else. And you'll see that the heart disease deaths are out here with the high levels of metals. People without the metals, they're dying of something else. If we look at lead, the only people with low lead that died of heart disease are the ones with the highest cadmiums and vice versa. So the people with high levels of metals were more likely to die of heart disease than something else. Here, if we look at the proportions of deaths due to cardiovascular disease, low lead and cadmium, you're going to die of something else. Something else is going to get you. The more lead, the more cadmium, the greater is your risk of dying of heart disease. Now, when we do chelation, we want to remove all these metals, but that's not all we do. We're going to talk to you about exercise, dietary modification, get rid of the trans fats, take your vitamins and minerals and fish oils. We don't just chelate you in isolation. That's stupid. We're going to chelate you as part of a comprehensive program. That's the way to get the best results. And we're going to look at your other risk factors, deal with endothelial dysfunction, look at insulin sensitivity, stress reduction, and I'm going to keep you on your medicines, but I might have to back off because you may not need as much blood pressure reducing therapy or cholesterol reducing therapy. If we're going to deal with the causes of cardiovascular disease, we can't just do bypass surgery or stents. We need to identify the causes of cardiovascular disease and eliminate them. And if you suffer from heavy metal or iron overload, you're going to wipe out your antioxidant defenses. You'll suffer from a high free radical burden. You're going to oxidize your LDL. You'll have endothelial dysfunction. Your blood pressure goes up. There's inflammation. So heavy metal overload underlies many of the other risk factors. So I'm painting a bad picture for metals, and I'm suggesting metals play a role in cardiovascular disease, and we're going to get rid of those metals with chelation therapy. Well, that makes sense in theory. Will it work? Here we have a study of EDTA and cerebral brain blood flow. We're going to carry out oculocerebrovasculometry, quite a mouthful. OCVM, what you do, you put a little pulse sensor over the carotid artery and over the eyeball to look at the retinal pulse. And if blood flow is uniform, the pulse amplitude's the same. If you got a blocked carotid artery, there's going to be a delay between the neck and the eye that can be quantified and used to estimate the degree of narrowing in the carotid artery. And here we're going to take 57 patients, do the study before and after 30 chelations. 88% of the patients improved. The average carotid narrowing reduced by 18%. All age ranges benefited. The younger people were not as badly plugged up. They improved. The older patients had more plaque. They also improved. Well, if we improve blood flow, is that going to help you? Well, you'd think that it might, but if your brain's full of lead, even good blood flow is not going to help you. But chelation will take out the lead. So if we take out the toxins and improve blood flow, will intellectual function improve? Here we're going to look at 15 patients with reduced cerebral blood flow and some sort of intellectual problem. You're going to measure cerebral blood flow with an isotope flow scanning technique, give them 1 chelation per week over 20 weeks with a vitamin and mineral, then you repeat the assessment. Now what they're doing here, they'll inject into your IV a bolus of a radioactive material, technetium, that'll bind to your red cells. So this bolus, this volume of labeled red cells goes back through the right heart, through the lungs to the left heart. It's going to be pumped up to the carotid artery. So you're going to put a radiation detector over one side of the head, and you'll see this uptick of radiation as the radiolabeled cells are pumped up through that carotid artery. Then there'll be a washout because unlabeled blood will push it out. Then the radiolabeled cells will dissipate throughout the entire body and then begin to recirculate, so you'll see kind of a background. But let's say this artery is badly blocked. The uptick will be delayed because the blood cells are only wiggling through the blocked artery. The unlabeled washout blood will also wiggle out through, so the tagged blood will hang up in the brain, and you'll see a plateau. To quantify this, you look at the B point, the equilibrium point, and you want a low B point. All the patients improved clinically. Their B point fell from 6.1 to 3.9, a 77% return towards normal. So blood flow improved, and they had a number of different problems, and they all improved functionally. Because you improve blood flow, you get rid of free radical stress, you depoison the enzymes, the cells function better. Now, we physicians are interested in carotid ultrasounds, measuring the percent stenosis. Here we're going to take 30 patients with carotid narrowings, do a carotid ultrasound. They get 30 IV treatments over 30 weeks with the standard vitamin and mineral, etc. Then you repeat the ultrasound, and as a group, they opened up by about 21%. Those that had higher grade, 70% or greater narrowings, improved even more. They improved by 35%. And if you improve flow a little bit, if you improve the narrowing a little bit, flow improves a lot, because flow through a tube is proportionate to the square of the radius. So if you have a high grade narrowing and you open up just 10%, blood flow is going to double. Now, I'm not that concerned with your cholesterol. I'm concerned with your oxidized cholesterol, but the rest of the world is really hung up on cholesterol. So let's see what effect chelation has on cholesterol. We're going to take 15 patients with hypertension, diabetes, kidney, or cardiovascular disease. We're going to give them daily IV chelation over 3 to 11 days. This is an older paper with a much more aggressive protocol than we would use today. And before and after this aggressive chelation, we're going to look at cholesterol or blood pressure. And here's the group with the high cholesterol, on average, fell by 55 points, from 204 to 148. One person fell from 518 to 412. Those with lower levels of cholesterol did not fall as much, but their cholesterol levels did fall. Now, why would that be? Lecithin cholesterol acetyltransferase is my favorite enzyme. Now, I know people, you're going to say, Robert's ought to get out, and like most people have favorite sports teams, and I have a favorite enzyme, but this is really a neat enzyme. The HDL, the good cholesterol, works via LCAT. LCAT will take a molecule of phosphatidylcholine, bind it to cholesterol to make a cholesterol ester to carry out reverse cholesterol transport. And I'll treat you with phosphatidylcholine to stimulate this reaction. This is the key enzymatic reaction that gets rid of extra cholesterol. Those of you with high cholesterol, you're taking drugs that poison the enzymes that generate cholesterol. This is the enzyme that removes excess cholesterol from your body, and it's poisoned by lead and cadmium and mercury. The reason that your cholesterol is rising with age is not your diet. Your kids eat junk. You watch what you eat, but as you age in America, you become progressively poisoned with metals. This enzyme is lost, you can't clear out cholesterol, your cholesterol goes up. So by detoxifying the enzyme, reverse cholesterol transport can proceed normally the way Mother Nature planned, and your cholesterol may fall. So we can lower cholesterol. Can we reverse diet-induced atherosclerosis? Here we're going to look at 36 New Zealand rabbits. 12 get standard rabbit chow. They're not going to have heart disease. 24 get chow with mazola oil and vitamin D, oxidized trans fat. That's going to produce plaque in a rabbit model. At 24 weeks, they receive either 20 IV chelation treatments or 20 saline placebos or no infusions at all. And then you sacrifice them and examine their arteries. The rabbits on a normal diet do not have cholesterol in their arteries or plaque. They have a low level of calcium. We'll call it a calcium score of 291, which was normal, the normal amount of calcium in the artery wall. If you give them IV saline, nothing happens. If you give them the normal diet and chelate them, there's less calcium. There'd be like an anti-aging effect. Now, more pertinent to the clinical situation with humans, if you force feed them oxidized fat, they're going to have cholesterol in their artery, they're going to have plaque, their calcium score is 777. If you treat them with the bad diet and saline as a placebo, there's no change. But if you force feed the high-fat, oxidized fat diet and chelate them in the artery wall, there'll still be cholesterol, no more plaque, and the calcium has been regressed. So in this animal model, chelation therapy reversed diet-induced calcific atherosclerosis. Chelation will lower your heart rate and blood pressure at rest and with exercise. That reflects better aerobic fitness. And if you can exercise without raising your heart rate and blood pressure, you're going to demand less oxygenated blood and you'll have less angina. The drugs we give you lower the heart rate and blood pressure. That's how they work, by decreasing the demand for oxygen. If we can lower heart rate and blood pressure with chelation and exercise, the same thing will occur. Here we're going to look at heart rate and blood pressure at rest and during a stress test before and after 30 chelations, and normally we would recommend exercise. For this study, they recommended the patients stay as couch potatoes. And they did the stress test, and you can see here's heart rate at the stages 1, 2, and 3, and this is before, this is after chelation. Your heart rate and your blood pressure is lower. It does not rise as much with physical activity, improving better arterial elasticity, better metabolic functioning of the heart. Here's a study of IV EDTA to lower blood pressure. We talked about this is the study where they gave the very aggressive chelation protocol with daily treatments, and it lowered cholesterol and it lowered blood pressure in this group on average 10 points systolic, 8 points diastolic, and they were able to cut back on the medicines because the toxic metals degrade nitric oxide, disrupt enzyme function. You know, another reason your blood pressure is rising with age is heavy metal overload. You get rid of the metals, your blood pressure is going to fall. Effective EDTA on iron. LDL must be oxidized by free radicals before it can become incorporated into plaque. Iron, along with lead and cadmium and mercury, are important accelerators of free radical reactions. Iron promotes and chelation protects against experimental cardiac injury in animals. The genetic iron storage disease, hemochromatosis, is associated with heart failure, diabetes, thyroid disease, and liver cancer. A ferritin, that is stored iron, above 200 increases a man's 3-year heart attack risk by 2.2 times and by 4.7 times if his LDL is high, because the iron oxidizes the LDL. So here we're going to measure iron levels in 122 patients before and after they received 30 chelations. They didn't measure ferritin, they measured serum iron because it was easier. For the entire group, the iron level fell by 17%. In those that had higher levels of iron pre-treatment, it fell more, 44%. In those that had low, normal, or abnormally low levels of iron, the iron level rose. Chelation levels things off. High values fall, low values rise. The people with high iron levels were overabsorbing iron. You're going to chelate out the iron. The people with low iron levels probably had some enzyme dysfunction. They weren't able to hold on to their iron. So you clean out the enzymes and the iron levels rise. We're going to see this again and again. High levels fall, low levels rise to get back into the homeostatic range, and you get that because you're depoisoning. Cadmium in the estrogen receptor. We're going to take 28-day-old female mice, take out their ovaries, so that's the only source of estrogen in females. The only way you can get estrogen is from the ovaries. Then you're going to administer into their belly cavity a pellet of estradiol, hormone replacement therapy, and anti-estrogen, sort of a tamoxifen. Cadmium at a toxic dose, cadmium plus the anti-estrogen, and a control group. You're going to look at their uterine response 4 days later and their breast response at 14 days. And they should be atrophied. They should not develop due to lack of estradiol. And what you find, the control animals have small uteruses, but if you give them hormone replacement therapy, they have a normal-sized uterus, 284 grams. And you can see the cells are plump and functional, the ducts are open, the animals that were deprived of estradiol, the cells are shrunk, they're dysfunctional. The animals that receive cadmium, it stimulates the estradiol receptor, and their uteruses aren't quite as large as those that got the real thing, but because cadmium stimulates the estrogen receptor, there is some proliferation that is blocked by the tamoxifen. If we look at mammary gland density, cadmium did almost as good a job as estradiol at maintaining normal breast development. This is a huge finding. Many of you are really perseverating and stressing. You're having menopausal symptoms. Should you take estrogen replacement or not? Because there's a small debatable risk of increasing your cardiovascular risk. There's a small risk of increasing your cancer risk. But why are you worrying about a small risk, a small increase of cancer, when you're ignoring this monstrous risk associated with toxic metals? The reason we're in an epidemic of breast cancer, and for us guys, prostate cancer, I believe, is because cadmium is stimulating the estradiol receptor. Estradiol causes prostate cancer in men, plays a role in breast cancer in women. It makes sense that the rates of prostate and breast cancer are skyrocketing as we pollute our environment with cadmium that we can't remove except via chelation approaches. Here we're going to take pregnant rats at 12 days of gestation, give them cadmium in a toxic dose or cadmium at a dose equivalent to normal human exposure, what you and I are being exposed to, and you evaluate the offspring and you find that the animals treated with the toxic dose or the normal human dose of calcium, breast development is accelerated, puberty occurred earlier. Occupational cadmium exposure increases breast cancer risk, 7 to 13% in white women, 50 to 130% in black women. For genetic reasons, probably blacks may be more susceptible to this than whites. Now, cadmium stimulates the estrogen receptor. It damages the DNA. It'll disrupt the DNA. But that's usually not a problem because we have enzymes, biochemical spell checkers, the post-replication mismatch repair enzyme to repair damages in DNA. So we're getting our DNA hit all the time, but not each hit turns into cancer because the biochemical spell checker will repair it, except cadmium poisons that enzyme. So it not only damages the DNA, it inhibits our ability to repair damage in DNA due to cadmium or any other toxin. So of course, it's going to be carcinogenic. EDTA and future cancer risk. Lead and cadmium from automobile exhaust and petrochemicals from automobile tires are in greater concentrations adjacent to highways. Lead promotes the carcinogenicity of aromatic hydrocarbons. Cadmium stimulates the estrogen receptor, is mutagenic, blocks DNA repair. Cardiac cancer mortality in adults living next to highways is greater than that of other city dwellers, as is disease in general. Iron is a free radical activator. Iron overload is associated with an increased risk of cancer as well as coronary disease. EDTA effectively and efficiently removes lead, cadmium, and iron. In animal studies, chelation with EDTA can slow the growth of experimentally induced cancers. Could EDTA, by virtue of its ability to take out these toxic metals, reduce cancer risk in humans? Here we're going to do a study that was done in Switzerland many years ago when gasoline still had lead. We're going to look at 231 Swiss, all lived in the same neighborhood adjacent to a busy highway, none with known cancer when the study began in 1960. 59 had symptoms of lead toxicity and were chelated. They got at least 10 chelation treatments. Their neighbors were not treated and served as a control group. And they went back and looked at these people 18 years later, and of the untreated neighbors, 30 or 17% had died of cancer, a variety of cancers. Of the 59 patients that underwent chelation therapy 18 years earlier, only one developed cancer. This makes sense. You take out the poisons before they have a chance to turn your cells cancerous, yes, you're less likely to develop cancer. This makes sense. Toxic metals in cardiomyopathy. Cobalt, arsenic, lead, and cadmium are associated with cardiomyopathy, and they also kick out selenium. There's a study here where you took people with dilated cardiomyopathies and do a heart muscle biopsy and compare the amount of metal with that of people with heart failure due to a known problem like hypertension or valvular disease, and they had some normal people that were dumb enough to undergo a heart muscle biopsy just for the heck of it. And what you find, the people with cardiomyopathy, heart failure of unknown etiology, unknown cause, had 22,000 times as much mercury in their heart as do the normal people. They are collectors of metals. You can see they have more antimony, more arsenic. For some reason, they didn't look at cadmium and lead, but I imagine you would find it. The greater the concentration of the mercury in the antimony, the worse was the pump function, the more complicated their arrhythmias. I don't think these people were exposed to 22,000 times as much mercury as normal people. I feel that these people, either for genetic or acquired reasons, are unable to defend against heavy metals. I think of cardiomyopathy as autism of the heart. When we talk about mercury, we'll talk about autism as a disease of unique genetic susceptibility to mercury. Any mercury blasts the kid's nervous system. They cannot defend against it. People with cardiomyopathy, I believe, cannot handle toxic metals that would not bother you and I. With that in mind, I've chelated patients with cardiomyopathy, and many have gotten better. Here's a woman that has high blood pressure. She presents with atrial fibrillation and arrhythmia and congestive heart failure. We converted to normal rhythm medically. I put her on a bunch of medicines and vitamins and coenzyme Q. I do a heart cath. Her arteries are normal. She's got a dilated cardiomyopathy. Her heart is just punk. Ejection fraction is 25 to 30%. It should be 50 to 60%. I do a provocative triple challenge, and she's got cadmium, lead, and mercury. That makes a lot of sense to me, so I begin to chelate her. And I'm going to take my own sweet time chelating her, but then all of a sudden we're in a hurry because she has a breast malignancy. They need to give her chemo, radiation, and surgery before the thing metastasizes. She can't take chemo with this type of heart. So now I'm in a rush. I have to really work hard and get the metals out. So I went directly to MME, magnetic molecular energizer therapy, that we're going to talk about in a couple weeks. But one of the mechanisms of MME is it rapidly and focally chelates the organ being treated. It drives the metals out. So she got 10 IV treatments. Then we found out about the breast malignancy. We treated her with 200 hours of MME because I had to fix this heart quickly, and that's what I did. This is her heart. It's not beating well. It's kind of like a sack of worms. And you can see there's a lot of mitral regurgitation. The valve was not working. And then a month later, the heart is squeezing with a normal amount of vigor, and the mitral regurgitation is all but resolved. By driving the toxins out of her heart quickly, I got the enzymes to work better. She could make more ATP, and we rapidly reversed the cardiomyopathy. She got the chemotherapy and the surgery, and all went well. But this shows how important these toxic metals are. Here's a study of 18 patients with symptomatic coronary disease. You measure their ejection fraction, the percentage of blood the heart ejects with each beat. It should be 50 to 55%. You give them 20 chelations, and then you repeat the study. They all improve clinically. Total resolution of angina in 16 of 18. Ejection fraction rose in 17 of 18 by about 6% on average. Here's the raw data. Nearly all of them improved. You get the metals out, the heart functions better. Effective EDTA on peripheral vascular disease, claudication. 77 elderly patients with 117 diseased limbs and an abnormal ankle brachial ratio. You look at the blood pressure in the arm, the brachial artery, and in the ankle. It should be 1. But if you have lower extremity plaque, the ankle brachial ratio will be below 1, reflecting the degree of narrowing. If, as a result of therapy, your ankle brachial ratio improves, that means we improve blood flow. So we're going to measure the ankle brachial ratio, given 26 chelations over 60 days, repeat the studies. Overall, they improved by 22%, from 0.77 to 0.94. The better leg didn't improve quite as much. The sicker leg improved more. The sicker you are, the greater the degree of narrowing, the greater is going to be the therapeutic kick of chelation or anything else we do. 10 patients with lower extremity vascular disease, abnormal ankle brachial ratio, calf pain walking 100 to 300 meters. You randomize them to receive 1,500 milligrams of EDTA with IV C and B complex, or as the control therapy, IV magnesium, vitamin C, and B complex. Now that's not really a placebo, that's an active therapy, but here you're going to get magnesium, C, and B with or without chelation. Double-blind protocol, so neither the subjects nor the researchers knew who was getting what. 20 treatments were planned, but they broke the code at 10 because it was obvious something was happening. Those assigned to chelation, their ankle brachial ratio rose from 0.66 to 0.8 after 10 treatments to 0.95 after 20. Those that assigned to placebo did not change with 10 fake treatments. Then they got the real therapy and they also improved. They looked at quality of life parameters, how many steps you could walk, how far you could walk, how far you could ride a bike. Here's someone that got chelation. They could walk 180 meters at baseline, 450 with 10 IVs, 760 with 20 IVs. A placebo patient, he could walk 200 meters at baseline, 220 with placebo, 480 with 10 IV chelation. So they all the patients that got 20 IVs steadily improved. Those that got 10 placebos did not improve. With 10 chelations, they did improve, as you would expect. Here's a large-scale study done in Brazil. 1,130 patients with lower extremity vascular disease and claudication. You do the baseline assessment, get 28 chelations, twice a week over 3 months, reevaluate their symptomatic status. Marked improvement at 91%. Pain-free walking distance increased by a factor of 5. The appearance of the legs returned to normal. Doppler blood flow studies are now within normal limits. Good improvement in 8. They increased their walking distance, but not 5 times the baseline. Partial improvement, unchanged or worse, only 1%. Similar study, 844 patients with coronary insufficiency, marked improvement in 77%. Their angina is gone. You get rid of their meds. Their stress test is normalized. Good improvement in 17%. Partial improvement in 4%. 2.5% unchanged, and only 1 in 884 worsened. Now this study, we won't get these results in the United States. This was done in Brazil at a time of hyperinflation, where the hospital medical system basically shut down and only the very rich could get surgery. So these people were desperate. They did everything that their doctors asked. They went on the right diet, they stopped smoking, they exercised, they did everything we would ask, they got chelated, and they all did well. Now that won't happen here, because if you don't do everything I ask and you don't get better, I can do your heart cath the next day and get a bypass. We have a safety valve here, so we won't get the same compliance as they do in Brazil. 10 years from now, we might. As we go into a socialized medical system, you have to wait a year for your bypass, but this just shows what can result with kind of perfect outpatient integrative medicine. Effective EDTA on lung function. Tobacco smoke and automobile exhaust contain cadmium, lead, and nickel, all of which we can chelate out. Now, could these metals contribute to pulmonary inflammatory damage? Smokers have lung disease. Even when you stop smoking, your lungs continue to worsen. Why is that? You stop smoking, but your lungs are still going downhill. Well, because the metal is still there, causing free radical stress. What if we took the metal out? Would that help your pulmonary function? Here we're going to look at 38 patients in a general chelation practice. Look at forced vital capacity. You breathe in and out of a drum, the maximum amount of air you can exhale after a deep breath. FEV1 is how much air you can exhale in 1 second. Those are the 2 parameters we use to assess lung function. They'll be impaired in people with emphysema. So you do the baseline, you give them 30 chelations over 30 weeks, you repeat the study. The forced vital capacity improved by 14%. The FEV1 improved by 15%. Now, if we look at those with the most advanced baseline disease, where their flow rates were below 70% predicted, they improved even more. The FVC improved by 19%, the FEV1 by 21%. only 2 of the 10 still were below their 70% predicted. So you get rid of the metals, any organ that's dysfunctional, due in part to metals, you take out the metals, yeah, it's going to get better. It could be the heart, it could be the brain, it could be the lung, or it could be the kidney. Bypass in Copenhagen. 470 patients undergoing chelation over a 6-year period, all chelated until their symptoms improved. They got at least 15, usually 20 treatments, and the ACAM protocol, vitamins, minerals, essential fatty acids, was followed. And 470 patients underwent chelation over a 6-year period, 265 for coronary disease, 262 for lower extremity vascular disease. Now, of the 265 coronary patients, 3 were scheduled for balloon angioplasty, 65 were awaiting bypass. Of those with lower extremity disease, 25 were scheduled for amputation. But in Denmark, they have a socialized medical system, as we will soon have, and you might wait for a year for your bypass. You might wait for 6 months for your leg to be cut off due to gangrene. This is what we have to look forward to because we've depleted our economic resources with our current approach to medical care. So these patients, instead of waiting for a year to undergo bypass or get their leg cut off, sought to undergo chelation therapy instead as an alternative. And of the patients with lower extremity vascular disease, about 80% improved. The younger patients did a little bit better than the older patients. Of those scheduled for an amputation, 92% improved, so only 3 underwent the amputation. The more therapy you give, the better the results. If you have less than 30 treatments, there's a 73% response rate. Above 50 treatments, they all got better. With cardiovascular disease, men and women both improved about 90%. Age was less of a factor. Of those scheduled for bypass, 85% improved, and only 6 got the bypass. Of the 3 scheduled for balloon angioplasty, 2 of them improved, but they all got their angioplasty anyways, because that's how we think. The greater the number of treatments, the better the result. Effect on the bottom line from the point of view of the patients. 82 of 92 on the waiting list for bypass or amputation canceled their procedure. 58 of 65 bypasses were canceled. 24 of 27 legs were spared. 241 of the 265 coronary patients improved. 216 of the 262 vascular patients improved. That's pretty good. Bottom line healthcare costs, 92 canceled surgeries saved the Danish Medicare program $6 million. Extrapolate that to the United States. Billions and billions of dollars could be saved and used to provide better food for babies and better education for our kids, instead of being, in a sense, used inappropriately, dealing with a metabolic illness with repetitive surgery. Now, I'm obviously pro-chelation. I'm going to present studies showing that chelation works. But again, not everybody agrees with me. Most doctors will say, chelation's unproven. It doesn't work. And they'll quote studies like this. Here's a study that shows that chelation doesn't work in Germany. 48 patients with lower extremity vascular disease, stable claudication, pain-free walking distance below 200 meters. You're going to randomize them to receive fludilat. That is an antiplatelet agent similar to pentoxifylline or silositol, antiplatelet agents that we use for claudication in the United States. 24 received a comparison agent. They picked an inert therapy. They picked EDTA. Now, this is not EDTA with magnesium and vitamin C. It's just EDTA in a bag of salt water. You measure the pain-free walking distance before, during, and after treatment in this randomized double-blind protocol of the drug fludilat and the inert EDTA. And the study was carried out by the distinguished Professor Dr. Shetler, President, International Atherosclerosis Research Association, Chairman, Department of Internal Medicine, University Hospital of Heidelberg, West Virginia. And the study was graciously funded by the Tiemann Pharmaceutical Company, the manufacturer of fludilat. Now, Tiemann reserved the right to review and edit the study results. They own the study. Did you know that when drug companies do studies, if they don't like the result, it'll never see the light of day? They don't have to publish. If something works at 3 months but not at 6 months, they can publish the 3-month outcomes and not the 6 months. And everybody signs a code of silence. So you're only seeing the studies that make a drug look good. Tiemann bought the rights of the study. The professors could not publish anything without Tiemann's knowledge and consent. So they presented at the 7th Atherosclerosis Congress in Melbourne, and they showed that Fludilat was highly effective. It increased pain-free walking distance at 30 days by 76%. The EDTA was no better than a placebo. It improved the walking distance by 70%. Soon after that, the American EDTA approved Trental, a similar agent, because it increased pain-free walking distance by 25%. The data was presented like this at the meeting, but the press release was chelation therapy is worthless, no better than placebo, and Fludilat is a wonder drug. Now, I'm not a statistician, but I don't see a big difference between 70% and 76%. But in the press release that the media picked up, they said chelation therapy was ineffective. Clever little trick they have there. Now, if we look at increase in pain-free walking distance at 30 days, there's a slight edge to Fludilat. But at 3 months, in the Fludilat group, you rise by 200%, you double. In the chelation group, you rise fourfold. As we'll discuss, the benefits of chelation are not obvious at the last treatment. It has to do with pulses of parathyroid hormone. So your best result is 6 months out. But they didn't report that. Now, one patient died in the drug group. Whenever you do a study and subpatients have really prominent responses, either way, they're considered outliers. They would skew the research results. And there's a reason for this. Let's say on the post-treatment treadmill, you twist your ankle. Well, you're going to throw that result out. That doesn't make any sense. Well, 4 of the patients assigned to chelation were outliers. They improved so much that they decided to exclude them. Now, their pain-free walking distance increased by 100 meters, 1,000 meters. If you would have included those at 30 days, EDTA would have blown away the Fludilat. But their statistician decided to make sure that their drug looked better than the inert chelation. So chelation doesn't work in Germany. It also doesn't work in Australia. 32 patients with advanced lower extremity disease. None are felt to be candidates for surgery. They're too far gone. Average ankle brachial ratio is 0.6 at rest, 0.3 with exercise, 2/3 smoked. They're going to get 20 treatments over 10 weeks. The placebo group gets 500 cc's of saline with B vitamins, with C, with a vitamin and mineral. So that's not really a placebo. The other group gets magnesium EDTA and the vitamins and minerals. And at baseline, after 20 minutes at 3 months, you're going to look at a number of parameters in a randomized double-blind format. Now, let's look at the ankle brachial ratio of the better leg. It rises 4 points with chelation. It falls 2 points with placebo, but that was not statistically significant. Ankle brachial index of the worst leg rises 3 points with chelation, falls 3 points with placebo, not statistically significant. Maximum walking distance rises a little bit more with chelation. Pain-free walking distance at 10%, actually placebo does a little bit better, but maximum walking distance on a flat surface, which is clinically relevant for patient outcome, chelation does better, 278 versus 199 meters, but it was not statistically significant. The femoral pulsatility index, which looks at arterial elasticity, was statistically significantly better with chelation, but all the other parameters, there was an improvement with chelation, but it was not statistically significant. The conclusion was chelation has no benefits. But what's wrong down under? These people had advanced disease. They were too far gone for surgery. 20 chelations is not enough. They would need 40 to 60. There was no placebo group. Both groups got a little bit better because they were both treated with vitamins and minerals and vitamin C. That we've already shown that improves blood flow. The results were log transformed, potentially muting a positive treatment effect. The placebo group had an outlier. some guy whose pain-free walking distance increased tenfold. That couldn't have occurred. He was a ringer, but they kept him. See what the statisticians do, if they don't want the chelation to look good, they say, oh, those are outliers. But if they want the chelation to look bad, the outliers in the placebo group are allowed in. So there's something about liars, damn liars, and statisticians. Now, chelation really doesn't work in Copenhagen. The Danish group published the chelation study, and all these people decided, instead of having their legs cut off, to undergo chelation therapy. So the vascular surgeons decided to do a proper, honest, medically appropriate study of chelation therapy. So what they did, 153 Danish patients with claudication, poor blood flow to the lower extremity. They all got 20 IV treatments, randomized to 3 grams of sodium EDTA. Now this is not EDTA buffered with bicarbonate or magnesium. It's just EDTA in a bag of salt water versus a bag of salt water. Double-blind protocols followed. And what they found, pain-free walking distance improved in both groups. 23 meters with EDTA, 37 with placebo. Maximum walking distance did a little bit better with EDTA, 61 versus 37 with placebo. The ankle brachial index improved 6 points with EDTA, 2 points with placebo. Most of the patients stayed about the same. There was no clinical difference, so both groups got a little bit better, showing that chelation therapy is worthless. This got published in Lancet, the most widely read journal in the world, showing that chelation does not work. But something smells in Denmark. The ACAM protocol was not used. Now they used sodium EDTA with no magnesium. That's not what we use. IV vitamins were not given. The oral vitamins contained iron. That was stupid. And just 60 milligrams of C. 60% were smokers, and we don't know whether they stopped smoking or what. Now, the ACAM physicians wanted to look at the data. Usually when you publish this stuff, you show the raw data in the article. We asked, or my guys asked to look at it. Well, we're not going to show it to you. And then it was lost. They lost the data. They could not find it. Now, they did report on side effects on the frequency of IV site burning, and there was no difference between those that got salt water. That doesn't hurt. But if I gave you EDTA without magnesium, without bicarb, it would burn like fire. You would not come back. But there was no difference in IV burning rates between the placebo patients and the chelation patients. That doesn't make any sense. There was a big brouhaha in Denmark about this, and it got into the media. So some of the subjects of the study came forward and were interviewed and said that the IV needle was placed in the clinic and they were given a bottle off the shelf to start at home. And some days the IV hurt and other days it didn't hurt. It's like every other IV hurt and the other didn't hurt. Now, isn't that interesting? This was not a randomized double-blind study. It was a randomized double-blind randomized study. If you want to conduct a study to show that an experimental therapy is no better than a placebo therapy, what better way would be to treat all the patients the same way? The patients assigned to 20 chelations actually got 10 chelations and 10 placebos. Those assigned to placebo got 10 placebos and 10 chelations. This was a fraudulent study. The chelating doctors sued them. It worked its way up the court. More and more subjects came forward. 2 American physicians, Dr. Chaplin, I think Dr. Rosema, testified in the Danish court case and listened to the testimony. And the subject said, yes, we were told the purpose of the study was to debunk this lie of chelation. And some days the IV hurt and some days it didn't. This was a fraudulent study. You see, what happened was the leg cutting off business slowed down a little bit, so they had to discredit the chelation therapy. It got printed, and Lancet refused to publish a correction or retraction because it's too controversial. But we all know what happened, and these doctors know what they did. And when they pass away and come up and have an interview with St. Peter, I hope St. Peter says, we're going to cut off your legs, and maybe they ought to cut off something else as well. Now, then our guys came back with a long-term follow-up study. There was 470 patients treated between 87 and 93. 92 have been scheduled for bypass or amputation. 82 canceled their surgeries. How are they doing 6 to 12 years later? Well, it was hard to follow these people rigorously, but 52 of the 92 were treated in a single clinic. Of these 52, all avoided the original surgery. 34 of the 52 were scheduled for bypass, 18 of 52 for amputation. How were they doing in 1999, 6 to 12 years out from their original commitment to surgery that they canceled after getting chelation? Of the 34 initially referred for bypass, how are they doing 6 to 12 years later? 34 began EDTA, 24 stayed with EDTA alone, 9 did need bypass later on, 1 had a stent, 3 died. Those that had EDTA only, 22 were better, 1 was the same, 1 was dead. Those that needed bypass, 6 were better, 1 died, 1 was the same, and 1 was worse. The single patient that got the stent died. Here's a timeline. Here's the year they began chelation, then some bypasses and the deaths. So you'd like to avoid the bypass, but if you can delay a bypass 5 years and the patient doesn't have an infarct, that's also a good outcome. So most of these patients were able to cancel their bypasses and do well. Some had to have a bypass, but they were able to delay it, which is an okay outcome as well. Of the 18 patients initially scheduled for amputation, 13 were available for follow-up. Here's where they began the chelation. 18 began, 5 were lost to follow-up, 11 were still with chelation only, 1 had died, 1 had had an amputation. That's a pretty good outcome in people that were scheduled for amputation 6 to 12 years earlier. Of the 34 facing bypass, 6 did not follow a maintenance program. When we chelate you, we get it out of the soft tissues, but not out of your bone. So we have to keep up with maintenance therapy 6 to 12 times a year. As your bone turns over, old lead goes back in your arteries, we have to dip in and take it out. So those that did not have maintenance therapy, they had a 50% event rate. 28 received some maintenance therapy, they had only a 28% event rate. Of the 13 facing amputation, 6 did not follow maintenance therapy. They did well, only a 33% event rate. Those that had maintenance therapy all did well. So it's not just the chelation to get the metals out, we want to keep up at a maintenance level to keep the arteries and the internal organs clean of toxic metals. Now, EDTA will lower your calcium level, and your doctors will say it'll lower it and you're going to have a seizure. Let's see if that happens. 80 patients scheduled to undergo chelation. You give them 30 EDTAs, treatments over 30 weeks. All receive a vitamin and mineral supplement. You measure serum calcium at baseline and after 10, 20, and 30 treatments. The average baseline level was 9.66. Most of them were within the normal range or just a smidge out of the normal range, as you can see here. What happened? Overall for the group, calcium fell from 9.66 to 9.57, well within normal limits. Those whose calciums were in the lower third, pre-chelation, their calcium rose from 9.25 to 9.53. Those that had higher levels of calcium, 10.06 fell to 9.80. EDTA is a leveler. The reason their calciums were out of whack is probably enzymes were dysfunctional. You clean out the enzymes, everything goes back into the normal range the way Mother Nature intended. But the message is, it's not going to lower your calcium too low. But is it going to cause osteoporosis? I had a patient who I recommended chelation to, and the doctor said, the acid will eat away at your bones. Let's see if that happens. Calcium levels fall by 9% during the drip, then rapidly return to normal. They're back to baseline in 9 hours. The maintenance of the normal calcium levels are responsive to the parathyroid glands. We have 4 parathyroids, 2 in each thyroid gland. Now the parathyroid glands are sampling the blood calcium level. When the calcium level falls, it releases its hormone, parathyroid hormone. Parathyroid hormone triggers the release of calcium into the circulation from sites of abnormal. We call that metastatic calcification, such as diseased arteries. It also promotes the release of calcium from bone over the next 30 days, and then the reincorporation of calcium in the bone over 90 days. So with each pulse of parathyroid hormone, you're going to pull it out of the bone short term and put it back into the bone long term, but take it out of arteries and joints and things like that. So we're going to look at the effect of EDTA on bone mineral density in 61 consecutive patients in a general chelation practice. The predicted density was 0.697. The actual bone density was normal at 0.7, and it improved a little bit. In those that were osteoporotic, low DEXA scores, low bone mineral density going into chelation, they should have been 0.707. They were osteoporotic at 0.624. They improved. So chelation therapy transfers calcium from abnormal sites into bone. I'm also going to suggest to you that cadmium and lead that are stored in bone lead to osteoporosis. And if we depoison the bones are stronger. But the message is chelation does not cause osteoporosis, it actually improves the situation. EDTA in the kidney. EDTA has a potential direct toxic effect on the kidney. Toxicity of EDTA on the kidney is favored by a high dose, if we give it too fast, insufficient rest interval between treatments, if you're lead or cadmium overloaded. If you're just soaking in lead and I grab it and I run it through the kidney too quickly, the kidney's not able to process that lead and cadmium out. It can get stuck in the kidney and damage the kidney. If you have pre-existing kidney dysfunction, you would be more susceptible to toxicity either from too much EDTA too quickly or if we run too much toxic metal through the kidney. So the potential for kidney toxicity is something that we must consider and examine closely. The role of the kidney, it filters blood, it excretes toxins and waste into the urine while retaining nutrients. What are the causes of kidney dysfunction? Well, high blood pressure, problems with blood flow to the kidney due to atherosclerosis, we call it renal artery stenosis, urinary tract obstruction, infection, autoimmune disease, and heavy metal toxins, lead, cadmium, and mercury. Now, we will dose you with chelation as a function of your size, your age, your gender, and your kidney function. If your kidneys are abnormal, I'm going to start with a lower dose of chelation, a lower dose of EDTA, because I know that if your kidneys are dysfunctional, you can only handle so much detoxification so quickly. So I will dose you as a function of your creatinine. And then I will measure your blood creatinine level periodically. And if it goes up, we will hold chelation for a while, maybe give you some vitamin C and magnesium IVs, and then your creatinine will fall back to normal. It always falls back to normal. If the creatinine rises, that is a functional problem, not an anatomic problem. So if your creatinine goes up, I back off for a while, let the kidney function stabilize, I will resume chelation at a lower dose, and then over time I will work it up. So as long as we're watching your kidney chemistries, I've never hurt anyone's kidneys as long as I'm watching what I'm doing. Now, if I just chelated you and never looked at your kidneys, then there's the potential for toxicity. But if I follow the American College for Advanced Medicine protocol, the risks are very, very low. Now, the creatinine, what is this laboratory marker of kidney function? Creatinine is made by the muscles at a constant rate. It's generated at a constant rate. It enters the blood, and it's filtered by the kidneys. So it enters the blood at a constant rate, it's excreted by the kidneys. If the kidneys become dysfunctional, your serum creatinine level goes up. If you have dysfunctional kidneys and we improve the kidneys, your creatinine will fall. So it's a lab marker of kidney function. Now, let's look at EDTA in the kidney. 383 patients scheduled to undergo chelation, measure a baseline serum creatinine, give them 10 3,000 milligram EDTA treatments over 50 days, repeat the creatinine following their 10th treatment. On average, the creatinine fell by 2%. That's pretty good. Individuals with low baseline creatinines below 1.0, the creatinine rose insignificantly. Individuals with higher creatinines above 1.6, they've got some baseline kidney dysfunction, the creatinine fell. Again, if something is abnormally low, there's a reason, probably enzyme dysfunction. We take out the metals, it'll rise to the normal range. If kidney function is abnormal, much of that is due to heavy metal toxicity. The creatinine might even improve over time. Chelating patients with poor baseline kidney function. 13 of 300 chelation patients in a program began with impaired kidney function. They got 20 standard treatments over 3 to 4 months. You record a 24-hour creatinine clearance, which is a more exact measure of kidney function. The creatinine clearance should be 100. In these patients, it was only 62.5, so they had lost a significant amount of kidney function. After 10 EDTAs, their creatinine clearance rose to 91. After 20s, it rose to 98. You clean out the metals, the kidney functions better. That seems like a good idea. So summarizing EDTA in the kidneys, in the 60s, physicians gave way too much chelation. They gave 6,000 to 10,000 milligrams. The FDA-approved dose, there's actually an FDA-approved dose of chelation is 3,000 milligrams, and I often give you less as a function of your body surface area, etc. They gave it over 1 to 2 hours, not 3 to 4 hours. They didn't look at kidney function. Many of the patients were lead toxic. They were painters who were lead toxic. So you give too much chelation, too fast, without a rest interval, the kidney was overloaded and people went into kidney failure and died. But that's because you gave too much, too quickly, and didn't watch what you're doing. With modern day chelation, with our understanding of the kinetics of lead and EDTA metabolism of the kidneys, millions of treatments are given every year. The protocol is designed to protect the kidneys. No EDTA-related deaths have been reported to the FDA. The risk of irreversible kidney injury is 1 in 30,000, and abnormal kidney function will actually improve with EDTA, as we've suggested. Here's a 64-year-old man, came to me with high blood pressure and kidney dysfunction. His blood pressure was controlled on 2 drugs, lisinopril, an ACE inhibitor, and HCTZ, a diuretic. His creatinine's 1.5, and that's mildly abnormal. It should have been like 1.2, 1.3. His renal ultrasound was normal. There was no obstruction. I do a triple challenge, and I see lead, as I would expect. So I treat him with chelation therapy. He gets 20 chelations. Now we've got him off the drugs. His blood pressure is normal. I repeat the challenge, and there's less lead. I got rid of the lead. I depoisoned him. His blood pressure improved. His kidney function improved. All of a sudden, he doesn't need the medicines because I dealt with the underlying problem rather than the consequences of the problem, high blood pressure. EDTA can improve kidney function. Lead's toxic to the kidneys. Kidney function's inversely related to lead levels. Now, we'd say that a toxic lead level is going to cause kidney dysfunction, but what about a normal lead level or mild lead overload? Could lead removal with EDTA prevent further deterioration in individuals with pre-existing kidney dysfunction? Here we have a study of 202 patients with moderate chronic renal insufficiency. The normal creatinine is about 1.3, depending upon the lab, 1.2 to 1.4. They were between 1.5 and 4.0. When you get to about 7 to 8, you're on dialysis. They've been stable for 6 months. Another measure is glomerular filtration rate. It should be about 100, and they were 32. They've got significant kidney dysfunction. They were not felt to be lead toxic. They were felt to have a normal lead burden in their body. None had jobs where they were exposed to lead. They did an EDTA challenge study, collected urine for 3 days, and found between 80 and 600 micrograms of lead in the urine. And that was considered normal. This was done in Taipei, which is similar to such as Toledo, a manufacturing city here in the United States. So these people had the usual amount of lead that a city dweller would have. The lead was not felt to be the cause of their kidney disease. Many had diabetes, many had atherosclerosis, many had high blood pressure. The lead was simply there. So the question comes up, if we remove that lead that's supposed to be a normal amount of lead, what effects that can have on the kidney? Now, first you're going to establish the natural history. You're going to measure their creatinine every 3 months for 2 years to see how they're doing on their own. Then you're going to assign 64 to a 3-month treatment period. One group gets dextrose IVs, D5 and saline IVs as a placebo. The other group gets 1,000 milligrams of chelation every week until their post-EDTA urine lead level had fallen below 80. And you're going to measure their creatinine every 3 months over the next 2 years. Concomitant medical therapy is the same. You're going to look at renal function. You're going to look at the treatment-associated cost to make sure it's cost-effective. Now, the blood lead level was below 10. You know, they're all normal. And with chelation, the blood lead level fell from 6.1 to 3.9. That's not very impressive. But blood lead level doesn't mean a whole lot. Their body burden, as assessed by their post-EDTA urine lead level, fell a lot more, from 151 to 43. So you got a lot of lead out of their body, a lot of lead out of the kidney. Here we're going to look at the decline in the GFR over the 1 to 2 year baseline period. You know, during this period, nobody got any IVs. This was the observation period. It's falling 3 points per year over 2 years. Then with the 3-month treatment period, it falls 1 point with placebo, but it improves 3.4 points with chelation. Over years 3 and 4, they're not getting anything IV. This is post-chelation or post-placebo. The placebo group continues to fall apart, and the chelation group deteriorates, but at a much slower rate. Here we can look at their glomerular filtration rate. Over the 2 year baseline period, they're going downhill. They're on their way to dialysis. The placebo patients proceeded on their way to dialysis. Those that got chelation over 3 months acutely improved and pretty much maintained their gain. So just 3 months of chelation interrupted this downhill course to dialysis. They calculated EDTA treatment should delay dialysis by 3 years. The cost of chelation was $3,700, including all the salaries and the research stuff. If we did it here in a Medicare-sponsored program, it would have cost only $1,500. The cost of 3 years of dialysis is $61,000. This was published in the New England Journal of Medicine, and it was also published, a similar study was published in Archives of Internal Medicine. Randomized double-blind study showing that low-cost chelation therapy arrested the deterioration of kidney disease in humans. I practice chelation therapy. I've been doing this for 10 years. How many patients have been referred to me by nephrologists for chelation therapy? Hasn't happened. It's in their journals. It's all over their journals. They know about it, just as I know about it. But why don't we recommend chelation therapy in kidney disease? Well, I think it might have to do that it costs $1,500 as opposed to $61,000. Perhaps that has something to do with it. But our healthcare system, we're making such poor decisions. Instead of depoisoning people for pennies, we ignore the poisons and spend thousands of dollars on drugs and surgery that are totally unnecessary. That's a shame. The biochemical effects of chelation: we lower the intracellular calcium and magnesium ratio, remove the toxic non-protein bound iron, we squelch damaging free radical reactions, we remove toxic metals, improving enzyme function, it repletes vitamins, minerals, and chromium and essential fatty acids as part of a comprehensive integrated program. We have a weak but definite effect on blood platelet stickiness. Many other risk factors fall into line. Up to a 90% response rate in angiogen and claudication. It will improve arterial flow, and all you got to do is open up an artery a little bit to dramatically increase flow. Provides effective treatment of heavy metal toxicity, stabilizes declining kidney function, benefits in other degenerative diseases, may decrease risk of future malignancy, improves lung, kidney, and overall metabolic function, lowers blood pressure, exercise heart rate, improves arterial elasticity, favorable effect on many risk factors. Risk of toxicity is minimal. No deaths have been reported. It's extremely cost effective. What chelation means to you: chelation can help stabilize cardiovascular disease, giving you the opportunity and responsibility to maintain your now improved health, freeing you of dependence on drugs, hospitals, and doctors. But chelation therapy is not in widespread use. There's only 3 physicians in Northwest Ohio offering chelation therapy. Medicare won't pay for it. Your insurance company won't pay for it. It's very difficult to obtain access to chelation therapy. Insurance and Medicare doesn't want to pay for it because it's not been proven to be effective. To become proven, you need to do a large, randomized, double-blind study. EDTA is off patent. There is no drug company that would fund such a study because they'd never get their investment back. So to study chelation, you need a government-funded study. Government-funded studies of chelation have started over the years, and then they're squashed for political reasons and economic reasons, as you can now understand. The TAC study is an NIH, National Institute of Health funded study. They're putting up $32 million for a randomized double-blind study of chelation therapy. Now, TACT, the trial to assess chelation therapy, would like to enroll about 2,400 subjects, at least 50 years of age. You can't be a smoker. You need reasonable kidney function. You need to be in TACT, you must have had a heart attack. It could be a small heart attack or a large heart attack. It has to be a heart attack at least 6 weeks before you enter the study, and you have to be stable. All will receive standard, proper, politically correct post-heart attack drug therapy. Statins, ACE inhibitors, beta blockers, aspirin. 30 IV treatments over 30 weeks, and then once a month for 10 months, and a multivitamin. You know, you're going to be randomized. Half will receive IV chelation, half will get IV placebo. Half gets a high-powered multi, a 6 a day like I would recommend, half get a 1 a day. So 25% of the subjects will get chelation therapy and a 6 a day multi, the way I would do it. 25% get chelation and a weak 1 a day multi. 25% get an IV placebo and a good multi. You're going to see a benefit there. And 25%, the double unluckies, get IV placebo and a weak multi. Now, the TAC study started about 2.5 years ago, and it's in big trouble. Not enough patients have been enrolled. The idea was to get 50 cardiologists and 50 chelating physicians. But cardiologists have not been at all excited. Only a few have joined on. And of the chelating doctors, their patients, they don't want to be in a placebo group. They know how good it is. So the study is in deep trouble. And if enrollment does not increase and increase soon, the NIH is going to cut off funding. And we will have lost our last best chance to prove our point. I did not get involved in TACT because as TACT was starting, I was getting involved in my magnetic molecular energizer program, which has taken a huge amount of my time. So I didn't get involved in TACT. Well, recently my colleagues have been not so gently twisting my arm, and the MME program's up and running, so we got involved in January, and we have 30 patients, and we need to get 30 more by the end of the year. We need to do more recruiting in TACT because we're going to show that it works. And then that opens the door for Medicare and your insurance company to say, hey, we're going to save some money. And then opens the door for further research, like maybe a study of chelating people before they've had a heart attack. So this will open the door for heavy metal detoxification in the United States. But we have to complete this study. So if you are 50 years of age, you do not smoke, you've ever had a heart attack, and you've not had chelation therapy, we'd love to hear about you. And you will get 40 IV treatments. Half of you get the real thing, half of you get a placebo. Neither you know or I know. And we're going to be looking at your outcomes. Mortality, stroke, heart attack. We want to show that outcome in this group of patients is improved with chelation therapy. So if you're interested in this, we would love to hear from you. There's a few perks if you participate in the TAC study. Plus, we give you this really nice t-shirt. So that's really worth it. So if you're interested in the TAC study, please let us know. You can learn more about the TAC study and chelation from my website, heartfixer.now, and then there's a link to the official TAC website to learn more about the TAC study. That's all I have to say. Thank you very much for your attention.